narasumber yang bernegeri, sehingga kami akan menggunakan bahasa Inggris. Terima kasih. Good morning, distinguished ladies and gentlemen. Welcome to Day 2 Stem Cell Webinar. I'm Yohana Kristi Sinurat, will be your host for today. Yesterday, we will learn about the stem cell through the expertise from Sarjito General Hospital speakers. And today, we are going to expand our understanding about stem cell through the insight from the National Taiwan University Hospital or NTUH. I will inform you that NTUH has been our value sister hospital since 2016, and we have been collaborating in the fields of transfer of knowledge, training, and medical innovation. So without delaying any further, let's begin our webinar by the opening speech from Professor Xiao Yushu, MD, PhD, as the CEO of International Medical Service Center, IMSC at NTUH. Please turn your attention to the screen.
Congratulations on the 43rd anniversary of Dr. Sarjito General Hospital. On behalf of National Taiwan University Hospital, NTUH, I'm delighted that our doctors can take part in this special celebration by hosting a webinar. First, I would like to introduce the esteemed speakers joining us today. Professor Li Haicai from the Department of Neurology will deliver a talk on stem cell therapy in stroke. Second speaker will be Dr. Chen Hongcai from the Division of Hematology, Department of Internal Medicine, who will present on bone marrow transplantation in adults. The third speaker will be Dr. Meng Youlu from the Division of Pediatric Hematology, Department of Pediatrics, who will deliver a talk on bone marrow transplantation in children. Dr. Sarjito General Hospital and NTUH have been collaborating since 2016, fostering a strong partnership and a lasting friendship. Over the past 9 years, we have jointly organized numerous academic events, strengthening our shared commitment to advancing medical knowledge and patient care. We hope this webinar will be both insightful and rewarding for everyone. We encourage all attendees to actively participate in the panel discussions to gain a deeper understanding of stem cell therapy and bone marrow transplantations. Finally, I would like to extend my sincere gratitude to everyone for joining this webinar. It is truly an honor to celebrate the 43rd anniversary of Dr. Sarjito General Hospital with all of you through this academic symposium. We look forward to continuing all our collaborations in the future, working together for health and well-being for all. May the conference be a great success, and may everyone enjoy good health and have all their wishes come true. Thank you very much.
Thank you, Prof. Chu, for the opening speech. We hope we could strengthening our collaboration in the future. So we are now moving on to the material presentation. I'm pleased to inform you that today's webinar will be led by Dr. Mardia Sucihardianti, PhD, SPPD Kahom. Please welcome Dr. Mardia.
Thank you, Dr. Yohana, for the kind introduction. I myself will serve as the moderator for today's session. And without further delay, I would like to invite the first speaker of today's agenda, Professor Dr. Lee Kaisai, to deliver his lecture on the development and application of stem cell in stroke. Dr. Lee Kaisai will give his lecture in 45 minutes ahead from now. So please welcome Professor Dr. Lee Kaisai. Time is yours.
Okay, thanks for your kind. Thanks for your kind introduction. Ladies and gentlemen, it's my great honor to be here and present something about stem cells and stroke to you. And I'm Lee Kaisai from Department of Neurology and Stroke Center, National Taiwan University Hospital. We know that stroke can be divided into ischemic stroke and hemorrhagic stroke. And for ischemic stroke or so-called cerebral infarct, in the past about 2 decades, we know that we can do the thrombolysis therapy and thrombectomy to help these patients. However, there's only about 20% of patients who can receive the thrombolysis or thrombectomy. And even the patient receive the reperfusion therapy, they still may have some severe neurological deficit. And we can divide the hemorrhagic stroke into intracerebral hemorrhage and subarachnoid hemorrhage. For intracerebral hemorrhage, maybe we can do the minimal invasive surgery for this patient. And the concept has been published in last year in April, which I published in New England Journal of Medicine. And for patients have the anticoagulant-related intracerebral hemorrhage, we can first do the reversal agent therapy for this patient to reduce the hematoma enlargement. But this kind of treatment only restricted in small groups of patients with intracerebral hemorrhage. And we know that most of the patients with SH is resulting from the rupture of aneurysm. So for this patient with SH, we can do the aneurysm clipping and embolization, but it only reduces the further risk of rebleeding from the aneurysm, but it cannot improve. This treatment cannot improve the patient's outcome. So how about neuroprotective agent? Unfortunately, until now, there is more than 50 drugs which have been tested in a phase 3 clinical trial, including, for example, acetaminophen, including edaravone, is a free radical scavenger, including nimodipine, that is a calcium channel blocker, which are all failed in the phase 3 clinical trial. And recently, we are anticipated in a novel neuroprotective agent called neranotide. However, about a few weeks ago, there is a phase 2 clinical trial which has been published, which show that the treatment outcome is not significantly improved in this patient with acute ischemic stroke. So in 2018, there is a review article which I published in Nature. They say that maybe new approach for brain repair is required, from rescue to reprogramming. So if we try to use the PubMed and use the keyword stem cell and stroke to see the publication number, you can see that in the past about 2 decades, the publication number increased years by years. It means that researchers or clinicians try to test this concept in the stroke field. So today I will try to show you in 2 parts. One is the direct stem cell therapy in stroke, and second one is try to enhance the endogenous neurogenesis for stroke treatment. About 25 years ago, researchers start to know that if you use the red mesenchymal stem cells to treat the animal model of acute ischemic stroke, and the method is used intravenous injection or intraarterial injection, you can see that these stem cells after injection can migrate into the stroke area with further differentiation. Differentiated into astrocyte, differentiate into neuron or endothelium. And most importantly, this kind of treatment can enhance the neurological recovery. It means that after stem cell treatment, the stroke rate have better functional outcome. So it opened a window that maybe stem cell therapy has a role in the acute therapy for stroke treatment. And there are many kinds of stem cell which can be applied in the stem cell therapy. For example, mesenchymal stem cells, neural stem cells, and others. And among them, mesenchymal stem cell is the most popular stem cell type for stem cell therapy. It's because there are many advantages to use the mesenchymal stem cell in this treatment strategy. For example, easy isolation, for example, bone marrow aspiration, easy amplification. The cell has relatively low immunogenicity. This has a paracrine effect, and it has the effect of immunomodulation. So if you try to see the meta-analysis, use the stem cells for acute stroke in the preclinical study, that is an animal stroke study, you can see that stem cell therapy grossly can improve the neurological function and is significant. And it can significantly reduce the infarct volume. And the treatment effect is consistent using different methods. For example, use a different kind of animal model.
他们slide 不知道为什么没有在或分享画面暂停。
Okay,
重新再
let's hold on.
它是暂停，你分画面分享暂停。
So is the slide moved now?
Slow loading. Loading. 还是没有。他们来说，好，那可能先暂停，我们先停止分享。刚刚我们蔡司是讲到第几页？Di 8 页。Profesor Chai sudah sampai ke slide ke-8.
Okay, so this slide shows that mesenchymal stem cells may be a good choice for stem cell treatment because it has many advantages. For example, easy isolation, easy amplification, low immunogenicity, paracrine effects, and immunomodulation. So please next slide. And in preclinical study, using stem cells to treat the acute ischemic stroke cell animal model, it can consistently have a benefit using different methods. From the slide, you can see that you are using the animal model of permanent middle cerebral artery occlusion, or use the temporary or transient middle cerebral artery occlusion. Both of them has a good effect. And you can test in male or female rate, the same effect. You can use the mechanical stem cells or neural stem cells. Yep, both have the same effect or a best effect, or a good effect. You can use different number of stem cells to treat. You can treat at a different timing. All of them has a good effect. Next slide. Next slide, please. And if we just focusing on the mechanical stem cells only in the preclinical study, you can see that, again, stem cell therapy can benefit the animal with ischemic stroke. And we can try to see the treatment effect with the definition of more than 0.8 to be a very good treatment effect, and more than 0.5 to be medium effect, and 0.2 to be small treatment effect. You can see that using different kind of assessment method or using different kinds of administration methods, they all have a very good effect size. And there is similar benefits between different treatment dose and between different treatment timing. Next slide, please. Okay. Actually, previously, we also have tried to test the mesenchymal stem cell treatment effect using an intravenous treatment method in our ischemic stroke model. And we did find that this kind of treatment can have a good treatment effect. However, after treatment, although these mesenchymal stem cells can homing into the stroke area, most of mesenchymal stem cells are still mesenchymal stem cells. They did, or some of them did differentiate into other cell type. For example, in C, it's differentiated to be astrocyte. In D, there is differentiation to be endothelium, but there is seldom differentiation. Most of them is still mesenchymal stem cells. And it seems to be, it lost the capacity to proliferate after homing into the stroke region. So now we know that there is multiple therapeutic mechanisms for stem cell therapy in stroke. For example, the stem cell therapy can modulate the immune reaction, enhance the endogenous neural stem cell proliferation, to potentiate neuroblast migration, to promote neuronal differentiation, to augment angiogenesis, and to affect neuronal plasticity. Unfortunately, there is seldom cell neuronal differentiation. It means that stem cell treatment can have the effect, but is less likely to have the effect of cell replacement. Next slide. So maybe homing into the stroke region, infarct region, is still very important. Previous study has demonstrated that there is only 2 to 4% of mesenchymal stem cell which can home or migrate into the infarct region. And previous study also showed that the number of stem cells homing into the infarct region is reversibly correlated to the infarct size. It means that homing number is still important for stem cell treatment. And why this stem cell can migrate or homing into the infarct region? Previous study has demonstrated is because of the SDF1 and CACR4 interaction. In the infra region, the cell can release the SDF1, and there is a CACR4 receptor on the mesenchymal stem cells. So through this kind of interaction, these stem cells can well homing into the infra region. Next slide. And previously, we also tried to see is it possible for us to increase the capacity for the stem cell homing into the infra region. We have demonstrated that pre-treatment, the stem cell with valproic acid, or so-called VPA, and the lithium can enhance the migration capacity of these mesenchymal stem cells. It's because of that valproic acid can enhance the expression of CACR4 protein through the increase of histone acetylation. And through the SDF1 CACR4 interactions, it can increase the migration capacity of this mesenchymal stem cell. And lithium can enhance the MMP9 protein activity through the inhibition of GSK3 beta activity. And with the MMP9 protein increase, it can also increase the intracellular matrix digestion and then increase the mesenchymal stem cells migration. Next slide. So we further try to pre-treat this stem cell with both valproic acid and lithium, and use this kind of pre-treat stem cell to treat the infarct rate. And you can see that pre-treat valproic acid lithium stem cells can enhance the mesenchymal stem cell homing, and it is associated with the reduction in infarct size and improvement of the functional outcome. Next slide. And others also try to use different kind of strategy to increase the homing capacity of these stem cells. It's because you systemically inject the stem cell into, for example, the vascular system. Mesenchymal stem cell may just return to a circulation without homing into the infra region, or infiltration of the stem cell to the perivascular space, or invasion of the stem cell into the brain parenchyma. And if we increase the concentration of the stem cell, for example, use an intra-arterial injection of the stem cells, it can increase the concentration, and research has demonstrated that intra-arterial injection can have the better homing outcome as compared to intravenous injection. In the middle, you can see that the black dot is the iron labeling stem cells. Using the MRI or scan, you can see many stem cell homing into the infra region. Next slide. And in addition, some researchers also demonstrate that mesenchymal stem cell can target not only brain CNS tissue, but also peripheral tissue, spleen, in the stroke. If the rat had a normal spleen, stem cell therapy can have the effect. If you treat the stroke rat with stem cells, and the rat had a normal spleen, then stem cell has a positive effect. However, if a rat already have the splenectomy, the stem cells will lose its effect to treat the stroke. And they also show that mesenchymal stem cell can restore expression of multiple genes involving in immune and inflammatory response after stroke. So they conclude that if a rat or human had a spleen, then stem cell therapy can reduce the expression of many cytokines after stroke and have the treatment effect. But if the target did not have a spleen, then stem cell cannot modify the immune inflammatory reaction so it loses the treatment effect. So it means that stem cells can have the treatment effect in the peripheral tissue, especially targeting the spleen. Next slide. So now we know that we can use the stem cell to do the therapy in stroke. Even use an intravenous injection, intra-arterial injection, or use the intracranial stereotactic injection directed into the brain. And it has many kinds of neurorestorative effects. For example, enhance endogenous neurogenesis, neurogenesis, and angiogenesis, synaptogenesis, inflammatory remodeling, or anti-inflammatory effects. But to use these stem cells into human, we still need to do the clinical trial. Next slide. Actually, a few years ago, I also wrote a review article that is to summarize the clinical trial at that time regarding the stem cell therapy in stroke. And at that time, you can see that most of them use mesenchymal stem cells, even either allogeneic stem cells or autologous stem cells. And most of them use an intravenous injection and treat the patients at different timing across maybe acute, subacute, or chronic stage of the stroke. Next slide. And it's a methodology of nearly all of the study. They treat the patient with different kinds of stem cells, but many mesenchymal stem cells. Divided the patient into two groups. One is the treatment group, intervention group, and the other is control group. And after treatment, they use different kinds of assessment scoring system. For example, multiple ranking scale, NIH scale, NIH scale, or Basel index, or to see the mortality. And most important, to see whether there is any complication, the adverse effect. Next slide. Next slide, please. And here is the meta-analysis or summary of the mesenchymal stem cell therapy in stroke patients, focusing on randomized clinical trials. And you can see that the mechanical stem cell transplantation can improve neurological outcome in patients with ischemic stroke. And it's associated with lower mortality rates with a risk ratio of 0.44 and is strongly significant. And using either multiple ranking scale, MRS, or NIH scale knee score, both of them demonstrate the positive treatment effect, and that is significant. Favor stem cell treatment for group. Next slide. And here I try to summarize some important results of the clinical trials. But further, I would like to exclude 3 of them in red because that is a treatment at subacute to chronic stage. Next slide. And let's see the remaining 9 clinical trial. It has been published from 2005 to 2021 with a patient number of 5 to 67. Actually, the number is still not very large. And the timing range from 1 day to 2 months. And they all use mesenchymal stem cells or bone marrow stem cells, either autologous or allogenic. And they inject the stem cell range from 1 million of cells to 1 billion of cells. And most of them use an intravenous injection, and 2 of them use an intra-arterial injection. And fortunately, you can see that all of them report the good safety of the stem cell treatment. And some of them show the positive treatment effect. And further, I would like to focusing on 2 studies. One is in green, That is a case study which has been published in 2017 in Lancet Neurology. It has a patient number more than 60. And the other one is I have labeled in red. That is a process study which I published in Stroke 2014. You can see that the green one has a positive treatment effect, but the red one has the negative treatment effect. And the main difference is the treatment timing. The positive effect, the case study treat the patient at a very acute stage is 1 to 2 days. But the negative result study, published in Stroke, you can see that the mean treatment timing is 2 to 3 weeks after stroke. So maybe acute treatment or early treatment is important for stem cell or this kind of stem cell treatment in acute ischemic stroke. Next slide. So let's see in deep of the green study. That is the case study published in Lancet Neurology. It's called Master Trial. And actually, it's the largest stem cell trial in stroke till now. It's a randomized double-blind placebo-controlled phase 2 trial using the allogeneic multi-potent adult progenitor cell, or you can call that multi-stem, with mesenchymal stem cells from bone marrow from other person. And in the trial setting, the stem cell should inject in the vein within 1 to 2 days after stroke onset. They did not try to inject the cell too early. For example, in the first several hours after stroke, because the environment is very tough at the very beginning of the stroke. And they don't choose the later stage because early treatment usually is very important. And you can see that they demonstrate that there is very good safety and well tolerated in this treatment, this kind of treatment. And the primary outcome is the percentage of excellent outcome at 90 days after stroke. Although there is non-significant of the primary outcome, but it's a trend toward good outcome with the stem cell treatment. And most importantly, if you follow up this patient to be 1 year after stroke, there is significant more excellent outcome in the treatment group. And they also find that the early treatment with a definition of 24 to 33 hours show even more benefit. So early treatment is still important. Next slide. And in this phase 2 clinical trial, they also show that after stem cell treatment, there is reduction of post-stroke inflammatory cytokine. And very interestingly, stem cell treatment, intravenous stem cell treatment can reduce serious adverse events in severe patients. For example, with this kind of stem cell treatment, it can reduce the possibility of patients to have acute respiratory failure, sepsis, renal failure, edema, or herniation. So in addition to improve the functional outcome in the brain, it also reduced the possibility of systemic complication. Next slide. So they try to do the phase 3 clinical trial. The so-called Master 2 is an international multi-center double-blind randomized control study. Actually, our hospital also enrolled or also involved in this kind of phase 3 clinical trial. And again, they use an intravenous stem cell treatment, and this time at 18 to 36 hours post-stroke. And it's our setting in our hospital. And they at first want to enroll the patient at around 300, but unfortunately, this study has premature start because of the financial issue. So you know that you can know that this kind of study is not very easy to perform because stem cell culture or stem cell maintenance should be aseptic, and it require large financial support to perform this kind of study, especially phase 3 study. Next slide. And actually, our researchers also try to do their best to improve the potential mesenchymal stem cell therapy in stroke. For example, try to do something to improve the survival of this mesenchymal stem cell after transplantation, or try to promote this stem cells migration capacity. For example, I have just said that we have shown that valproic acid and lithium pretreatment can improve these stem cells after transplantation, and try to see whether they can do something to promote the neurogenesis or angiogenesis enhancing effect. And here is some example of the strategies. Next slide. And how about the chronic stroke? For chronic stroke, anti-inflammation is not very important, but cell replacement is important in this kind of stage for treatment of stroke. And Berbasis trial is one of the large stem cell trials in chronic stroke. And at the very left, you can see that in this trial, it's an open label dose escalation phase 1 trial. You use the allogenic human neural stem cell. At this point, they use neural stem cell because neural stem cell can have more capacity to do the cell replacement. And although the patient number is not very high, it's only 11, but it shows it's a high safety, well tolerated, and because the enrolled patient have the stroke with a post-stroke stage of 6 to 24 months. So supposedly, this patient usually did not have very good improvement further. But you can see that after treatment, they have the functional improvement even after the post-treatment stage of more than 6 months. But it really relatively invasive because it do the intracranial stereotactic injection, directly inject the stem cell into the putamen. But they show that they had a high safety. So they directly go into the phase 2 clinical trial, collect the patient with a number to be 23, and again, they demonstrate a safety. And again, show the improvement of these patients in 1 year post-treatment. But it still did not have a control group. So the phase 3 trial, Berbasis 3 trial is ongoing now, and they will collect more than 100 patients who will receive the intracerebral stem cell treatment at 6 to 12 months post-stroke. And the stem cell type is a neural stem cell, or so-called CTX0E03, which is from human cortical neural epithelium. And you can find the trial algorithm or something detailed in this publication that is in Frontier Stroke 2023. Next slide. And we have just said that cell replacement is not very possible for acute ischemic stroke in stem cell therapy. So how about not to directly inject the stem cell, but inject the intracellular vesicle or secretome from the stem cells? Intracellular vesicle, or so-called EV, is a combination of the microvesicles and exosomes, which has a lipid, protein, and microRNA inside. And secretome is a mix of the trophic factor, cytokine, or chemokine produced through paracrine secretion. And with this kind of strategy, that is a new clinical, feasible, and cell-free paradigm. This strategy can avoid cell-related problems such as tumor formation and infarct caused by vascular occlusion during transplantation. Next slide. And here's the simple algorithm of this kind of treatment. You can try to collect the exosome from animal or from patients and inject the exosome or EV into the body of the stroke rate or stroke patients. And these exosomes can pass through the blood-brain barrier into the brain and target the neuron, endothelial cells, or others. And they can have their effects through the pinocytosis, membrane fusion, or just target the cell signaling. Next slide. And here is a meta-analysis of using exosome treatment in preclinical study regarding stroke. They found that mesenchymal stem cell derived exosome treatment can reveal therapeutic potential for ischemic stroke, which show the reducing infarct size and enhancing functional recovery after treatment. Either treatment within 24 hours or after 24 hours can have the exosome favorable treatment effect. Next slide. And here is a mechanism of the exosome treatment, including angiogenesis, neurogenesis, neuroprotection, neuromodulation, rejuvenation, and thrombus resolution and recanalization by these multiple intravenous contents of protein or microRNA. Next slide. And currently, there are some clinical researches on exosome utilization in stroke. And first of three is just use the exosomes to predict as a biomarker to predict the stroke type or stroke outcome. But the other four is use the exosome to test the treatment effect in stroke patients. And among them, the red labeling the study has been published in 2022, and they only collect 5 patients and demonstrate the safety of the exosome treatment in stroke patients. However, they did not show very clear the functional data. So other study results is still anticipated. Next slide. And next, I would like to use some time to show you use the another strategy to treat the stroke. That is the enhancement of endogenous neurogenesis. Next slide. About 60 years ago, researchers start to know that there is neurogenesis in the brain. And from right, they also show that there is 2 main regions to create the neurogenesis. Focusing on subventricular zone, that is just near the ventricle, and the other one is a subgranular zone that is around the hippocampus. Next slide. And left side is our data, is a red brain which had a middle cerebral artery occlusion, or so-called infarct red, is an infarct brain on the right side. And using the green Ki-67, last slide, please. And using the Ki-67 labeling, you can see that there is many green cells that is a proliferating cells in the brain after stroke, especially at the subventricular zone and also the frontal temporal lobe and also striatum. And on the right side, there is a study showing 87 men who had a right middle cerebral artery infarction but expired at the day 5 after stroke. And in the postmortem brain, they demonstrate there is a proliferation cell in the infant brain, and there is also neural stem cells in the infant brains. So it's not only occurred in the animal, but also in human. Next slide. And now we know that neural stem cells are primarily or essentially located at the subventricular zone area, labeled in red in upper part or green in the lower part. And after acute ischemic stroke, this stem cell can proliferate, migrate, and differentiate in the infra region robustly. And this kind of neurogenesis is important for stroke recovery because on the right side, research has demonstrated that if you ablation this neural stem cell, then the infarct will be worsening. So it raises an important concept that neurogenesis capacity is important for stroke recovery. So if we can try to enhance the neurogenesis capacity in a stroke, then we can maybe have the treatment effect for acute ischemic stroke. Next slide. And to demonstrate the importance of the neurogenesis in human, we have performed some interesting study. We collect a patient and record the clinical data. And we suppose that in this patient, they will have the neurogenesis and there is some good factor to trigger the neurogenesis. And this good factor can diffuse into the ventricle. And if we can collect this CSF with the good factor inside, then we can study these good factors after stroke. And we also collect the red neural stem cells in a culture medium. And we try to treat these red stem cells with human CSF and to see the treatment effect and correlate the data to the patient's clinical data. Next slide. And first, we use the animal model to test this concept. It's focusing on subarachnoid hemorrhage. It's a SAH animal model. And at the middle, you can see that it's a red brain after subarachnoid hemorrhage. Red is time-dependent increase of proliferation or neurogenesis in the subventricular zone. And if we collect the CSF of this SH red, you can see that this CSF has some good factor which can trigger the neurogenesis of the culture stem cells. And we further found that the good factor is the brain-derived neurotrophic factor, BDNF. Next slide. And then we go into the patients. We collect some patients with SAH and also collect the clinical data and the CSF of these SAH patients. And first, you can see that the post-SAH CSF can enhance the neural stem cell proliferation of the red culture stem cells. And the proliferation capacity is correlated with the human SAH volume. And then we can also see that the proliferation promoting capacity of post-SAH CSF is correlated with clinical outcome. It means that the CSF should have some good factors which can trigger the neurogenesis. And the capacity of neurogenesis, if if it's high, then it can have a better outcome after stroke. Next slide. And we also see this concept into the intracerebral hemorrhage, ICH. And again, it shows that in the red brain, and the red had the ICH, there is a post-ICH neurogenesis in the subventricular zone. And if we treat the red stem cell, culture stem cell with CSF collected from the ICH rat or ICH human, it can enhance the culture cell to proliferate or differentiate it into the neurostem cells, which can be blocked by BDNF antibody. So it means that there is the BDNF in the ICH CSF, both ICH CSF. And with this BDNF, it can promote neurogenesis, and which is associated with functional good outcome. Next slide. And we also try to use different methods to detect this kind of neurogenesis in the brain. Here we use the FLT PET study to do the study in fact, rate and also patients with ischemic stroke. And first, you can see that there is high signal in the infarcted brain of the rate. And the signal is time dependent. It decays in 1 month after ischemic stroke of the rate. And the signal is correlated with the infarct severity. And this kind of signal can be inhibited by a neuroblast inhibitor, MAM. And it means that after stroke, after ischemic stroke, there is increase of proliferating capacity in the brain, which can be detected by the PET scan, FLT PET. Next slide. And here's the patient's data. We collect some patient with middle cerebral artery infarct and use the FLT PET to detect the proliferation of the cells in the brain. And you can see that the positive signal of the PET is highly correlated to the infarct region. And the signal is also positively correlated to the infarct site. So again, it proves that we can do some non-invasive investigation to detect the neurogenesis in the brain. Next slide. And here is a summary of some growth factors or small molecules of protein which can promote the neurogenesis or angiogenesis in the brain, which have been published in different journals and also show the positive treatment effect in the stroke, no matter it's a preclinical study or clinical study. Next slide. For example, is a story about valproic acid. In preclinical study, previous study had demonstrated that valproic acid treatment in the animal can enhance the neurogenesis and angiogenesis with good functional outcome. Next slide. And here is the patient study conducted in Taiwan. And it also showed that valproic acid can improve the functional outcome post-stroke. Next slide. And it's a story about minocycline. Another study demonstrates the capacity of the drug to promote the neurogenesis in the stroke rate. And it's dose-dependent associated with the better function and survival after treatment. Next slide. And here's the human study. It first showed that after minocycline treatment, there is a good functional outcome. And on the right side is a meta-analysis study using a minocycline treatment for acute ischemic stroke. And demonstrate that the treatment can have a good effectiveness for treatment in patients with acute ischemic stroke and also animals with ischemic stroke. Next slide. And here is about the growth factor we conduct in our hospital. And we use the growth factor, including epidermal growth factor with combination with fibronectin. With this kind of combination, it can promote the neural stem cell proliferation, migration, and differentiation. Next slide. And we also try to see whether treatment of the this combination of the growth factor can improve the stroke rate. And it showed that after treatment, this rate has a good functional outcome through the effect of neurogenesis and inhibition of the apoptosis. Next slide. But it still did not have the patient data. And it's about a combination of the growth factor. We call that, it's a drug called cerebrolysine. In animal study, cerebrolysine can improve the animal after stroke, the animal's outcome after stroke. And actually, cerebrolysine is a drug which can modulate the endogenous expression of many kinds of growth factors. And it can enhance the post-stroke neurogenesis, angiogenesis, synaptogenesis, anti-inflammation, and neuroplasticity. On this slide. And from the SCAS pilot trial, actually it has been published in Stroke a few weeks ago. And it demonstrated that after cerebrolysine treatment in patients, it can significantly improve the functional outcome of these stroke patients. Next slide. So now we know that we have two kinds of treatment strategy. One is the direct stem cell treatment in stroke patients or animals. The other one is use the growth factors or small molecule to enhance the endogenesis or angiogenesis. But researcher also has one good idea that combination of the two treatment strategies, that is to modify the stem cell, to let the stem cell to prescribe more growth factor. So after you directly treat the stem cell into the stroke patients, this stem cell can have its previous treatment effect. And this stem cell can also provide more growth factor to enhance the neurogenesis and angiogenesis of this stroke brain. So with a combination, maybe the future possibility of the stem cell related therapy. Next slide. So in summary, first, stem cell related therapy can show consistent benefits in acute ischemic stroke preclinically. And clinical trial will potentially demonstrate the usefulness of this kind of novel therapy. Unfortunately, until now, there is still no large phase 3 clinical trial demonstrate the effectiveness and safety of the stem therapy in stroke. But future result of study, especially phase 3 study, is anticipated. And second, endogenous neurogenesis plays an important role in stroke recovery, which may be an attractive therapeutic target for stroke treatment. And combination of these two concepts for stroke treatment is also anticipated. On next slide. Okay, so thank you very much.
Professor Lee Kai-sai, thank you very much for your very complete and comprehensive lecture. We really learned the historical timeline of how stem cell therapy in stroke has been developed from animal model 20 years ago to ongoing and current clinical trials. We also learned that exosomes collected post SAH, cerebrospinal fluid, and many other substances to combine with stem cell for optimizing the outcome for stem cell application in stroke. From you, thank you so much for your wonderful lecture, and we invite all of the participants, the audience, to deliver question in our chat box. You can write in the chat box or directly asking to Professor Sai at the end of today's webinar. And now we would like to invite the second speaker, Dr. Cheng Hong Sai from National Taiwan University Hospital, to deliver bone marrow transplant in adult. In 45 minutes, we will be listening to Professor Sai. So please, time is yours, Professor.
Very much. Thank you very much for the kind of introduction. Can you hear me clearly?
Yeah, we do.
Okay, let's start. Good morning, ladies and gentlemen. First, I would like to thank for the organizing committee to let me have the privilege to share transplantation in adults in the 43rd anniversary celebration. My name is Xavier Tsai, and now works in the National Taiwan University Hospital and serve as the Secretary General in the Taiwan Society of Blood and Marrow Transplantation. These are my disclosures. And this is the topic today. First, I would like to share the overview of transplantation in Taiwan, followed by 4 major advances during the past 10 years, including donor-specific antibody, PT post-transplant cyclophosphamide as GVHD prophylaxis, especially we switched it from GIHD approach. And the third one is GVHD treatment. And the last one is the CMV prophylaxis and treatment. The TBMT registry is a nationwide BMT registry operated by Taiwan Blood and Marrow Transplantation Society. And through collaborative efforts, we have published several studies on VOD, haploidentical transplantation, PTLD, T-cell lymphoma, and other fields. Now there are more than 10,000 patients in this registry, and it continues to grow by approximately 500 patients per year. This is the AP-BMT survey in 2020, which demonstrated that transplantation numbers in Taiwan are increasing, have increased over the past 15 years. With more young staff dedicating their efforts to this field, we are striving to catch up with South Korea, Japan, and Australia. Almost all hospitals with the capability to perform transplantation have been covered by the registry, spanning from northern to southern Taiwan and from the west to east. There are a total of 23 transplantation centers in Taiwan, and National Taiwan University Hospital is the largest one. This is the distribution of recipient age. Here you can find a growing number of older recipients, reflecting advances in conditioning regimens and supportive care. This trend suggests that transplantation is increasingly viable for aging populations, a consideration for Indonesia as life expectancy rises and chronic disease increase. The majority of patients received grafts from unrelated donors, 44%, and 35% of patients received allograft from matched sibling donors, and 20% from haploidentical donors. Regarding the cause of death, the majority of patients died of disease relapse, while 11% died of graft versus host disease. And this is the overall survival stratified by transplantation type. The median survival for patients receiving allotransplantation is 3.3 years. And here we can see that in our registry, haploidentical transplantation has poor outcome compared with unrelated donors. One of the reasons is the pre-transplantation disease status. From the right panel, you can observe that patients with low or intermediate risk disease have a 2-year survival rate of more than 50%, where it is around 30% for those with high or very high disease, risk disease. The patients receiving allograft have a 1-year non-relapse mortality of 17%, a 5-year NRM of 25%, and a 10-year NRM of 28%. The haploidentical transplantation patients have the highest NRM rate compared with unrelated donors at a rate of 44% at 5 years. And after patients are discharged following transplantation, they are followed at outpatient departments. And due to the medical system in Taiwan, we can allocate around 8 to 12 minutes for each transplantation patients at each visit. Some transplantation centers have case managers dedicated to transplantation patients, while others have case managers who also care for cancer patients along with transplantation patients. And now we have some GVHD prophylaxis drugs. Some are reimbursed by the government, including cyclosporine, tacrolimus, methotrexate, mycophenolate mofetil, and ruxolitinib in terms of chronic GVHD, especially for lung GVHD. And some items not reimbursed but available in Taiwan, including ibrutinib and abatacept, and ECP also available but not reimbursed. And we also have some drugs not available yet, including belumosudil and azacitidine, which are presented, I think, during the past 2 years. And in Taiwan, we have made strides in standardizing care for chronic GVHD, particularly pulmonary complications. In 2023, the Taiwan Society of Blood and Marrow Transplantation and the Society of Pulmonary and Critical Care Medicine collaborated on a consensus. A steering committee drafted 24 statements on diagnosis, surveillance, and treatment, reviewed by a panel of 17 pulmonologists and hematologists. After 2 voting rounds, using a Likert scale and a 75% consensus threshold, we finalized guidelines and put on the TBMT website. This structured approach could inspire Indonesia to develop local protocols for GVHD management. And education is the key to better transplantation care. Over the past 2 years, the society have trained all members with organ-specific sessions, including dermatologists, ophthalmology, pulmonology, and other specialties. And we have held TBMT Academy for junior members. The topics cover donor selection, graft versus host disease, and the transplantation, post-transplantation relapse, etc. And regarding the nursing staff, we have sessions about GVHD assessment. This comprehensive approach ensures our teams are equipped to handle complications. And we have built up a BMT app, which is interactive between patients, case managers, and physicians. There are patient education resources and record forms, including such as temperature, blood pressure, heart rate, and any subjective symptoms for the patients. Now let's talk about how research is pushing transplantation forward in Taiwan. We are deeply involved in cutting-edge clinical trials, such as ruxolitinib REACH2 and REACH3 studies. It's a tracking steroid refractory GVHD with solid results. Then there's ibrutinib in the INTEGRATE trial, exploring how new options for chronic GVHD at frontline, and gilteritinib in the MORPHO trial is aimed to preventing relapse in AML patients after transplantation. And venetoclax, part of the VIOLA-T study, is boosting outcomes in transplantation settings. We are also testing other new drugs with novel mechanisms. And one I'm particularly excited about is our own investigator-initiated trial, combining eltrombopag with growth factor for stem cell mobilization. Let me dive into the eltrombopag trial. It's a phase 2 study we have run to see if adding eltrombopag to growth factor can improve stem cell harvest, and the results are promising. Compared with historical controls in the left panel, on the first day of apheresis, 92% of patients in the eltrombopag arm hit the target of at least 2 million CD34 positive cells per kilogram, compared to just 62% in the control arm. That's a statistically significant difference with a p-value of 0.04. Not only that, but the eltrombopag group collected more CD34 positive cells overall on day 1. This means faster, more efficient stem cell collection, which cuts down the patient's time and resources. And here comes to our second part about donor-specific antibody. First, about donor-specific antibody, this is a big concern in mismatched transplantation because of donor-specific antibody can increase engraftment failure rate and lower overall survival. This is the MD Anderson data. 18% of patients had donor-specific antibody, and they found that if a patient have DSA, the engraftment rate is lower, although the time to engraftment was similar. And looking closely, you can find that patients with subsequent complement activation have a tremendously high graft failure rate. 100% patients experience graft failure, suggesting that DSA is very critical in mismatched transplantation. To deal with the DSA, a standard desensitization has been proposed, including plasma exchange to remove the exit antibody, rituximab to eradicate B cells, IVIG, and with or without buffy coat from the donor. In adults with hematologic malignancies referred for allotransplant, up to 40% have anti-HLA antibody when there's a HLA mismatch, and DS specific antibody appears in up to 24% of cases, and in haploidentical transplantation, it ranges about 10 to 21%, much higher in female patients at 86%, especially those with multiple pregnancies, where it reaches 50%. Transfusions, particularly leukocyte transfusion and platelet transfusion, also raise the risk. This shows DSA is not uncommon. So there are 2 methods for DSA evaluation, the cell-based assay and the solid-based assay. In Taiwan, we prefer to use solid phase assay because it is easier to get an objective data, the exact number to tell us how to manage such kind of patients, and more scientific data available to support solid phase assay in hematopoietic stem cell transplantation. On the contrary, cell-based assay are more used in solid organ transplantation field. The ideal is to choose donors with no donor-specific antibody against them. It is the easiest way to avoid trouble, but in haploidentical transplantation, this is not always possible because donor options are limited. In Taiwan, we had to find solutions where DSA-free donors are not available, and that leads us to desensitization. It's a practical option you might explore in Indonesia when donor choices are few. When DSA cannot be avoided, we use desensitization. This means don't lower DSA levels before transplantation to reduce the risk of graft failure. First, we give some, although it was designed to give bortezomib, but we are not giving it in our institute. Instead, we give just plasmapheresis, IVIG, rituximab, followed by transplantation. And one important thing is the TBI dose. We will increase it from 2 gray to 4 gray to enhance the engraftment. And this approach was tailored to each case, and we found it is quite effective, especially when patients have a DSA higher than 2,000 MFI. And next, let's talk about the key change in Taiwan using post-transplant cyclophosphamide or PTCY for GVHD prophylaxis. We have moved from the older GIH approach because PTCY works better. It promotes immune tolerance by targeting alloreactive T cells and is straightforward and effective, especially in haploidentical transplantations. PTCY is not limited to haploidentical transplantations. We use it in matched related donors, matched unrelated donors, and mismatched unrelated donors. But I would like to highlight that for matched related donors, the EBMT consensus did not recommend use PTCY as the standard approach because most studies evaluating PTCY, they compared one group PTCY, one group with ATG, but one group without any immunosuppressant, but not with ATG. So it is debatable whether PTCY outperforms ATG approach. So the EBMT consensus did not recommend PTCY as a standard approach for patients receiving matched related donor transplantation. And the central concept of using PTCY is the immune tolerance. When we giving cyclophosphamide on day 3 and day 4 after transplantation, we can eliminate the alloreactive T cells, but sparing regulatory T cells, resulting in decreased graft versus host disease incidence and severity. And PTCY with haploidentical transplantation, PTCY started with haploidentical bone marrow. In the first beginning, it is proposed by Professor Leo Lusnik in Johns Hopkins. They use bone marrow as their primary stem cell source. They use PTCY was started after bone marrow stem cell infusion, which is now using peripheral blood stem cells worldwide with satisfactory engraftment. At our institute, I think 95% of patients receive peripheral blood as the stem cell source in terms of PTCY setting. The first human report was from Leo Lusnik, showing it could reduce acute GVHD or extensive chronic graft versus host disease. And this approach also works well for matched donors. The BMT-CTN 1703 phase 3 trial, which was published on NJM 2 years ago, it compared PTCY to tacrolimus and methotrexate and outperformed them in GVHD-free, relapse-free survival with a hazard ratio of 0.64 and a p-value of 0.001. That's a 36% lower risk. And of course, a lot of physicians may state that patients receiving PTCY have a higher infection rate, especially viral infection. The BMT-CTN 1703 companion immune reconstitution study presented in 2 years ago in AGE meeting. They showed that PTCY patients had a bottleneck of T cell number. The y-axis is a T cell number and diversity around day 63. And after that, the immune recovery improves. And for mismatched unrelated donors, a phase 3 trial tested PTCY with sirolimus and mycophenolate mofetil. 20 patients had reduced intensity conditioning, showing that GVHD rate and promising GVHD rate and the inspiring overall survival and progression-free survival. The following 15 MMUD trial enrolling 40 patients with myeloablative and 40 with reduced intensity conditioning, and the 1-year survival rate was 76%. This is encouraging for mismatched cases, showing PTCY's potential. Before PTCY, we used the GIH protocol from Beijing. It involves the GCSF from donor stimulation, ATG before transplant, strong immunosuppressant, and using a mixed peripheral blood and bone marrow stem cell as the stem cell source. It gives fast engraftment and a low relapse rate, but GVHD and the infection risk were higher than with PTCy. And in Taiwan, we use the GIC protocol since 2012 and start to use PTCy after 2017. So we have a lot of patients using either GIAC or PTCy as a GVHD prophylaxis for haploidentical transplantations. So this is Taiwan data. We compared modified GIAC to PTCy data with or without ATG for GIAC, and for GIAC patients, GVHD rate at day 100 is 16%, and for PTCy with ATG patients, it was 14%, and for PTCy without ATG, it was 11%. The difference was not statistically significant, but this suggests the PTCy is reliable either way. And currently, more and more patients in our institute using PTCy as the standard GVHD prophylaxis. And here you can see the chronic GVHD rate. The GIAC has a 40% of patients experience extensive chronic GVHD, but less than 20 or 10% for patients receiving PTCy of the GVHD prophylaxis. And the third one is the GVHD treatment. GVHD can be subclassified as acute or chronic disease. Acute and chronic disease were previously distinguished by the timing of their onset. The acute one was classified as symptoms presentation before day 100 after transplant, and the chronic GVHD was classified as symptom presentation after day 100. This classification was refined by the National Institute of Health, the NIH Consensus Conference in 2005, and the distinction between acute and chronic GVHD is now based on the feature of the disease. Chronic GVHD can affect any organ I'm sorry, there's a code and I need to, okay. And chronic GVHD can affect any organ in the body, and but acute GVHD primarily affect the skin, liver, and the gastrointestinal tract, the largest organ with a large surface area, with no time limit on diagnosis. Disease that fulfill the NIH definition of chronic GVHD is subclassified as either classic chronic GVHD or overlap GVHD if they are concurrent with acute GVHD, irrespectively the time of GVHD onset. Okay. And a chronic GVHD affected the skin with rashes or blisters, the GI tract with diarrhea and pain, and the liver with cholestasis. And chronic GVHD is broader. It hits the skin with sclerosis type GVHD, plus the mouth, eyes, GI tract, liver, lungs, genital tract, and even joints. Knowing these signs helps us to diagnose it fast. And although steroid works quite well in patients with acute or chronic GVHD, there are still some patients who respond either poorly to steroid or become steroid dependent. So there is a new definition of steroid refractory GVHD, including resistance and dependent. And for resistance, it defines patients either progression in any organ after 3 to 5 days of treatment, or failure to improve with 5 to 7 days, or incomplete response after 1 month of treatment. And for steroid dependence, it means patients cannot taper steroid under 2 milligrams per kilo per day after initial successful treatment for at least 7 days. And for steroid refractory acute GVHD, ruxolitinib is a key option, and now works as a standard second-line treatment for patients who not respond to steroid so well, either refractory or dependent. Ruxolitinib is a JAK1 and JAK2 inhibitor. As you know, it works very well for patients with myelofibrosis, and it can inhibit the JAK-STAT pathway effectively, resulting in the regulation of pro-inflammation genes, not just to target on the mutated JAK2 clone. The REACH2 trial, a phase 3 randomized study with 309 patients, showing that 62% of patients on ruxolitinib while using 10 milligram twice per day had a response by day 28, compared to 39% with the standard treatment. Odds ratio was 2.64, a highly significant p-value less than 0.001, and side effect that like thrombocytopenia occurred in 33%, but is now a standard choice. And for chronic GVHD, there's a REACH3 trial tested ruxo in 329 patients, also published on New England Journal. At week 24, 49% of patients of ruxo arm had a response versus 25% in the standard treatment. Odds ratio 2.99. Also, the p-value was less than 0.001. It's very effective for steroid refractory or dependent chronic cases, making it ongoing treatment in Taiwan. And I would like to introduce the belumosudil because it might be enter market, Taiwan market this year. It's a ROCK2 inhibitor. It's another advance approved by the FDA in 2021 for chronic GVHD. It targets pathway like stage 3 and stage 5 to reduce inflammation and fibrosis. It's a rising star in the treatment, offering hope for patients when steroids fail. And this is the ROCKSTAR study, a phase 2 study evaluating ROCK2 inhibitor for patients with chronic GVHD to either arm A with 200 milligram once daily or arm B 200 milligram twice daily. And the results showing the CR rate was 6% and partial response rate was 69%. It's amazing, 75% overall response rate, and the failure-free survival at 6 months was 73%, at 1 year, 57%, with a very high, extremely high 2-year overall survival of 87%. So a lot of guidelines now listed belumosudil as the standard treatment for third-line treatment, but you can see there are still ongoing trials evaluating combination of belumosudil and ruxolitinib as standard second-line treatment for patients failed steroid. And our final part is the cytomegalovirus prophylaxis and treatment. And post-transplantation complications can be categorized based on the timeline following transplantation. In the early phase, patients are at risk for infection, especially for cytomegalovirus. Here we can find that patients might experience cytomegalovirus infection before engraftment. And its duration can last for at least 12 months later. So either, as you know, that when we treat patients with CMV infection, we use either ganciclovir or foscarnet. And either kind of treatment will compromise bone marrow engraftment, lower blood cell count. So it's very critical to develop some method for patients with CMV infection before engraftment. Excuse me. And cytomegalovirus is a major concern in transplantation patients with a very high seropositive rate in general population. The rate of CMV infection vary worldwide, with some regions report prevalence exceeding 90%. For example, in solid organ transplantation, the risk was around 16 to 56%, but for bone marrow transplantation, the risk was 30 to 70%. And especially for those high-risk patients with either acute or chronic manifestation of graft versus host disease or receiving allografting from serological mismatched donors. And I would like to highlight this issue because here we can see that in Asia, South America, and some countries in Africa, the prevalence of CMV infection is much higher than those patients in North America or Europe. So this issue is extremely important for us, especially for Asia area countries. And the risk of CMV infection is influenced by multiple factors, including the sero status of donor and the recipient. For example, because most of the patients experience reactivation of CMV. So if the recipient is seropositive, then if the donor immune system not recovery yet, the CMV reactivation happens. So the most high risk lies in the subgroup of recipient positive and donor negative, because the donor immune system not knowing whether CMV is an enemy or a friend. So donor negative, recipient positive, this is the most highest risk group. Other risk factors including the presence of graft versus host disease, the degree of immunosuppression, and the seropositive recipient receiving grafts from seronegative donors are at particularly high risk. Other contributing factors including the intensity of the conditioning regimens, the use of T-cell depletion strategy, and the time elapsed since transplantation. The longer time between transplantation and the diagnosis, the higher risk of CMV reactivation. But the reason I would like to highlight CMV, other than we are in the high seropositive countries, but also there are some major advances over the past 3 decades. The first is the identification. We used to check CMV from Shield viral culture to CMV antigenemia, and now move to CNA PCR, which identifies CMA fragment DNA. So we call CMV viral load. Actually, it is CMV DNA amia. And the second one is we move from treatment to preemptive therapy when patients CMV viral load higher than 1,000. Then we move to prophylaxis strategy, especially for high-risk patients. And third one is the treatment. We used to have ganciclovir and letermovir foscarnet only. Now we have maribavir, which is currently now the standard second-line treatment in Taiwan. Recent years, we have some development of new antiviral agent targeting CMV, letermovir, which is approved for prophylaxis in CMV seropositive transplantation recipient in FDA 2017 and the Taiwan FDA 2018, had significantly reduced the incidence of CMV reactivation. And the maribavir, a newer antiviral drug, have been shown to effectively inhibit CMV DNA amia in patients with resistant or refractory CMV infection, providing an alternative to traditional therapies approved by FDA in 2021 and the Taiwan FDA 2 years ago. So I would like to first introduce maribavir, which is reimbursed by the government last November. This is the Solstice trial, one of the leading trials using maribavir. Patients with a relapse or refractory or intolerance CMV infection are assigned in a 2-to-1 ratio into the maribavir arm or investigator-assigned therapy, either via ganciclovir, foscarnet, or cidofovir. As you know, cidofovir has very high renal toxicity and now not available in Taiwan. After 8 weeks of treatment, patients are followed for 12 weeks. And during the treatment course, it means the end of week 8, 55% in the maribavir arm had response compared to 23% of patients in the investigator-assigned treatment arm had a response. And even after treatment, just giving them 8 weeks of treatment, at 12 weeks, 16 weeks, 20 weeks, the maribavir arm patients respond still very well to previous treatment. It means it might eradicate CMV more deeply, more completely, so less patients in the following period had CMV reactivation. And about the treatment-related adverse event, patients treating with maribavir had dysgeusia. It means test abnormality. Patients might test like metal or different, just different tests compared with before, not like post-chemotherapy sensation, around 46%. But while we are discussing myelosuppression, which is a major concern for patients using ganciclovir, you can see that 30% of patients have myelosuppression compared with only 3% in the maribavir arm. And for nephrotoxicity, which is a major concern in forthcoming treatment, you can see that 27% in the forthcoming arm have acute kidney injury, but only 1.7% of patients in the maribavir arm had nephrotoxicities. And the second is letermovir. And here I would like to share the landmark study published in 2017 on the New England Journal that patients, if they are CMV seropositive, they can enroll in this randomized multi-center, double-blind, placebo-controlled pivotal phase 3 trial. It's a 2 to 3 randomization into letermovir arm or placebo arm. The patients start to receive letermovir between day 0 to day 28 and given until week 14. And of course, there is a day 200 data last year published on Lancet, but the result is similar. So I just share you with the landmark study of this phase 3. And you can see that in the letermovir arm, either in the total group, the high-risk subgroup, or low-risk subgroup, those patients in the letermovir arm had the lower clinical significant CMV infection or reactivation rate. So here comes to the summary. First, we share the hematopoietic stem cell transplantation trends in Taiwan. The trends are increasing, and we share that actually care to care such kind of patients needs multidisciplinary teamwork, including the physicians, not only hematologists or transplanters, but also pulmonologists, gynecologists, urologists, or gastrointestinal specialty, and of course, very important, infection doctors. Also, nursing staff. I think nursing staff, especially case managers, is a very key role in the transplantation team. And of course, other including nutrition specialists or other kind of physical therapists or other things. We need a lot of members to group a very potent multidisciplinary transplantation team. And for the major advances during the past 1 decade, donor-specific antibody is quite important. The presence of DSA is associated with a higher incidence of graft failure rate and worse overall survival, not only in haploidentical transplantation, but also in mismatched unrelated donor transplantation. So in our institute, we evaluate anti-HLA antibodies in every mismatched transplantation, including unrelated or related donor transplantation. It is quite important to make patients engraftment. And the second thing is the PD side. As you know, we will move from GIHC protocol to PD side. The ratio is around 8 to 2, now comes to 1 to 9. More than 90% of patients receiving PD side strategy in our institute. And of course, if we brought our spectrum to all over Taiwan, I think there are only 2 hospitals have capacity to do bone marrow harvest currently. So most of the transplantation centers, just like I said, there are 23 transplantation centers. Most of the centers using peripheral blood of the stem cell source. So the PDCY works very well to reduce the rate of either acute or chronic extensive chronic GVHD and achieve comparable survival outcomes for not only haploidentical transplantation, but also mismatched unrelated donor transplantation. The third one is ruxolitinib, which is now the standard care of treatment for patients experiencing steroid-refractory acute GVHD or steroid-dependent chronic GVHD. Now, the government in Taiwan reimbursed it in lung GVHD, in patients with lung GVHD, especially the chronic form. And I need to point out the rising star is the belumosudil, which is they got the license in Taiwan this early year, and will enter our market, maybe reimbursed next year, but firstly with out-of-pocket route this end of the year. And finally, the evolutionary CMV management is quite important. We have now moved from preemptive treatment with ganciclovir or foscarnet to prophylaxis of using letermovir in high-risk patients, especially those with mismatched unrelated donor transplantation or haploidentical transplantation. And now we have a second-line standard new drug, maribavir, which has a lower chance of bone marrow suppression and a lower chance of nephrotoxicity. So this is the end of my talk. Thank you for your attention.
Yeah, thank you so much, Dr. Cheng Hong Sai, for your very structured and comprehensive lecture. I myself is an adult hematologist and very interested in your talk. Thank you so much. You have shared the development and current status of hematopoietic stem cell transplant in Taiwan, as well as we also learned several points of how to anticipate the failure of engraftment, how to anticipate GVHD, and you also have underlined the risk of infection, particularly on CMV in post-transplant patients. Thank you so much. And again, we would like to invite all the participants in this webinar to raise the question by writing in the chat box or directly communicate with the speaker at the end of this webinar. Again, thank you, Dr. Sai.
Thank you.
Yeah. And now we come up to the third speaker, the last speaker of this session, Dr. Meng Yao Lu from National Taiwan University Hospital, who is going to share about bone marrow transplant in children. So please welcome Dr. Meng Yao Lu. Your time is 45 minutes.
Thank you, the chairman introduction. And dear ladies and gentlemen, since the invitation of Dr. Sajata General Hospital, it's my honor to participate in this meeting. Today, I have the lecture about the pediatric hematopoietic stem cell in children. Next, please.
Okay.
Do you see the slide?
Not yet. We are preparing to show the slide from here, Doctor?
Yes.
Yeah. Okay. Wait a moment, please. Yes. So have you seen it, Doctor?
Yes.
Yeah. Okay. Please.
So, and my talk is a three-part. First, I talk about the specific aspects in pediatric transplant. Second part, I review the thalassemia major treatment and about the transplant for thalassemia major. Third part, I share our experience about the SCID newborn screening and the transplant in our hospital. Next, please. First, about the specific aspect about the pediatric transplant, I divided two subtopics about the indication, donor selection, graft source, conditional regimen, pharmacokinetics, psychological aspects, and the donor safety. Next, please. The indication for pediatric transplant is different from adult. In malignancy disease, pediatric acute lymphoblastic leukemia usually receive transplant in second remission status because the survival rate in only chemotherapy group is above 90%. So we did not do the transplant in the first remission, but only infantile acute lymphoblastic leukemia and ETP type T cell acute lymphoblastic leukemia receive transplant in the first remission because poor prognosis in the two type acute lymphoblastic leukemia receive chemotherapy. Now, CAR T cell therapy and new immunotherapy is used in B cell acute lymphoblastic leukemia. This new treatment improves the B cell acute lymphoblastic leukemia outcome. So the transplant number decreased recently. In solid tumor, only neuroblastoma and Ewing sarcoma to receive autologous transplant in first-line treatment have the evidence-based support. And medulloblastoma receive auto transplant only in young children aged below 3 years old because the radiotherapy is too toxic and more low side effect in young children below 3 years old. We should be avoid the radiation side effect. So the patient will receive auto transplant to replace or delay radiotherapy. Next, please. About non-malignancy disorder, the indication in pediatric disease are complex and different from adult. Congenital disease, such as thalassemia major, primary immunodeficiency disease, and metabolic error disease, will be in children only and cured only by allo transplant. Now, enzyme replacement therapy and gene therapy may treat and control some disease. Next, please. This congenital disorder first made a definite diagnosis and genomic type, then search the reference to confirm the efficiency of transplant. Not all disease and genotype will be treatable by transplant. In general, transplant will be arranged as soon as possible. But some disease, such as adrenoleukodystrophy, will be select the timing to transplant according to the some criteria. Next, please. The slide shows the indication for transplant in primary immunodeficiency disease. Severe combined immunodeficiency disease is curative by transplant and receive transplant as soon as possible before infection. In Taiwan, newborn screening, including SCID, we hope arrange transplant before 3 months old in this SCID patient. But some immunodeficiency such as Nemo deficiency. Nemo syndrome is controversial for transplant because Nemo syndrome has other organ anomaly, and the transplant do not cure the anomaly. Next, please. Metabolic error diseases are also complex. Next, please. The slide shows the indication, the recommended donor type, condition regimen, and the transplant timing. For example, adrenoleukocyte dystrophy transplant is indicated in early cerebral inflammation process disease. We need follow-up brain MRI change as low score every year, and arrange transplant when there are early MRI trends of demyelination. But when adrenoleukocyte dystrophy progress to advanced stage, like have the seizure cerebral palsy muscle dystrophy, transplant is a contraindication because transplant do not stop disease progression in this advanced stage. So the time of transplant for adrenoleukocyte dystrophy is depend on the brain MRI low score change. Next, please. About the donor type, adrenoleukocyte dystrophy favor match unrelated donor because the complication about the transplant is low. Match unrelated donor is less choice. Haploidentical transplant is rare indicator due to more complicated transplant outcome. Condition regimen favor standard myeloablative regimen because high graft failure rate was noticed in adrenoleukocyte dystrophy transplant. The stem cell source favor bone marrow than the PB stem cell. Next, please. The donor selection is similar to the DAT. Acute leukemia favor allo transplant, and solid tumor favor auto transplant to avoid the GVHD and little benefit in graft versus tumor effect. Non-malignancy disease favor allo transplant. Allogenic donor prefer matched sibling, then matched unrelated donor. Then donor selection, then haploidentical or mismatched unrelated donor. Donor selection must consider the risk of transplant complication, such as GVHD. Next, please. About the graft source, bone marrow and the peripheral blood stem cell are similar in as adult. PB stem cell has more incidence of chronic GVHD, but GVHD may have GVL effect. So malignancy disease prefer PB stem cell, and non-malignancy disease favor bone marrow source to reduce the risk of GVHD. And because of the body weight factor, cord blood is more applicable in the children only. Next, please. About the condition regimen, malignancy disease favor myeloablative regimen to eradicate the malignancy cell, and specific the underlying disease. Neuroblastoma and Ewing sarcoma usually use busulfan and methadone protocol. Acute leukemia favor busulfan and endosan or total body irradiation and the endosan regimen. Non-malignancy disease favor non-minor ablative regimen to avoid the side effect, but it depends on the underlying disease. Metabolic disease and thalassemia major favor milder ablative regimen due to more graft failure rate. And immunodeficiency disease favor reduced intensity regimen. But in general, radiotherapy will be avoided in the children because the long-term side effects such as secondary malignancy, growth, and then endocrine problem. Next, please. The slide shows the primary immunodeficiency disease suggested condition regimen. It is depend on the genotype, residual immunity, donor source, HLA matrix status. It can select non-condition regimen or reduced intensity regimen. And in some immunodeficiency may need mild ablative regimen. Next, please. About the pharmacokinetics, I mentioned two drugs, busulfan and cyclosporine. Next, please. Busulfan is recommended dose adjustment based on the therapeutic drug monitor, but the therapeutic drug monitor is not available in most centers, even in Taiwan. We suggest the dose by body weight. There are two protocols was recommended. One cut is at the 12 kilogram. When body weight below 12 kilogram, 1.1 milligram per kilo every 6 hours. When body weight over 12 kilogram, 0.8 milligram per kilogram every 6 hours. Next, please. Another protocol is cut more body weight level. And the body weight below 9 kilogram, the dosage is the 2 milligram per kilo per dose. The body weight 9 to 16 kilogram, 2.4 milligram per kilo per dose. 16 to 23 kilogram, 2.2 milligram per kilo per dose. And 23 to 34 kilogram, 0.9 milligram per kilo per dose. If the patient over 34 kilogram, 0.6 milligram per kilo per dose, and every 12 hours to use. And in the busulfan use, busulfan dose is different oral form and the IV form. Oral form is need more dosage than the IV form. It will be noticed. Next, please. About cyclosporine, children have required and tolerate higher dosage than adults. For example, in our experience, IV form cyclosporine changed to oral form. The dosage in children maybe need 3-4 increase, but in adolescent maybe only 1.54 increase. The dose adjustment based on the therapeutic drug monitor, and in our clinical practice, we will monitor every week, and then after adjust the dose, we will monitor the TDM after 5 doses later. Next, please. About psychological aspects, children encompass different age and consequence different cognitive, decisional, and emotional capacities. That make psychological intervention for more facility than adult. In addition, psychological intervention should also take in charge at high extent the need and the expectation of patient's family. Next, please. About the donor safety, we mentioned when donor body weight less than please, the previous slide. When the donor body weight is less than the recipient, PV stem cell is suggested due to PV stem cell may create more stem cell in harvest. But when donor body weight is less than 20 kilograms, it is important to notice the safety of PV stem cell harvest. In our practice, we arrange the PV stem cell harvest in the pickup to monitor the vital, to cross monitor the vital sign in the PV stem cell harvest process. Because the PV stem cell harvest process, the blood loss is the BP is very unstable. Next, please. Now, I review thalassemia syndrome and the thalassemia major treatment and the transplant. Next, please. The outline include introduction thalassemia syndrome and the thalassemia major treatment, allo transplant for the thalassemia major, and the alternative donor and our experience. Next, please. Thalassemia is an inherited blood disorder caused when the body does not make enough hemoglobin. Symptom is anemia and depend on the type, can vary from none to severe symptoms. Next, please. Thalassemia syndrome depend on the severity of anemia and the requirement of transfusion. Divide this to 3 groups. Thalassemia minor, the patient is asymptomatic and no transfusion need. And non-transfusion dependent thalassemia, the patient is symptomatic and need occasional transfusion. And transfusion dependent thalassemia, or thalassemia major, this group is severe symptomatic and need regular transfusion for lifelong. Next, please. Now, the current treatment of thalassemia major have 4 strategies. The conventional treatment is supportive care only. The patient needs lifelong transfusion and iron chelation therapy. The outcome of thalassemia major has improved dramatically in the past 2 decades due to improvement in supportive care, blood transfusion, and iron chelation therapy, and about donor blood safety. Now, the new RBC maturation therapy is the new treatment strategy. The treatment improves the ineffective erythropoiesis, so increase the RBC production and the survival to improve the hemoglobin level. Now, luspatercept is approved in use in thalassemia major, and some new drug is in the clinical trial. The curative therapy is the gene therapy. Gene therapy has already become a clinical reality. Use virus vector or CRISPR to replace the key element of beta globule gene or induce gamma globule gene production. Some clinical trial has acceptable result, but gene therapy is currently limited and expensive. And allogeneic transplant is the only curative treatment for thalassemia major in real world. Transplant can replace the defective erythropoiesis, and then the patient hemoglobin increase and do not need further transfusion. Next, please. Next. And matched sibling donor transplant for thalassemia major has the favorable outcome and with the long-term thalassemia-free survival. So matched sibling donor transplant is the first choice. Next, please. Since 1980, there are many reports to prove the acceptable result of matched sibling donor transplant for thalassemia major. You can see the thalassemia-free survival are over 80% in this report. Next, please. And allogeneic matched sibling transplant is currently considered the first choice, the only curative standard treatment for the thalassemia major, which can holding its own risk to release the patient from lifelong treatment about the blood transfusion and the iron chelation therapy, and possible avoid the iron overload complication. And the alternative donor transplant should be considered in some experienced transplant centers. Next, please. In late 1990, Pesaro Group has proposed a risk classification for pediatric patients undergo matched sibling transplant for thalassemia major. The classification depends on 3 risk factors: inadequate iron chelation, hepatosplenomegaly over 2 centimeter, and portal fibrosis. If violated in the pediatric patient only, please see the feature. The thalassemia-free survival in class 1 is better than the class 2 and 3, but it did not predict risk in adult. There is no clear definition the adequate iron chelation, and hepatosplenomegaly has the observed variation. Liver biopsy is the invasive procedure, so the classification is not optimal. In our experience, age is another risk. The transplant age is below 6 years old had a good better prognosis. Next, please. The thalassemia major transplant is favor mild ablative regimen. The regimen include the busulfan and the endosulfan. This is the standard practice. The regimen should be aware of hepatic and cardiac toxicity due to iron overload and chemotherapy toxicity. And anti-thymocyte globulin will be considered to act in the regimen to prevent GVHD and enhance engraftment, especially in high-risk group. Because autoimmunization induced by frequency transfusion in the thalassemia major patient may result in the high graft failure rate. So ATG may increase engraft rate and reduce graft rejection. Next, please. Next, please. Okay. About alternative donor, matched and related donor transplant is acceptable outcome recently. Li Qin in China report in 2012 let's lay high resolution HLA matched and related donor and use intensive conditional regimen, including busulfan, endosan, fludarabine, shiotepa, and the GVHD prophylaxis use cyclosporine A, ATG, MMF, and the short-course methotrexate. The results show the next slide, please. The thalassemia-free survival is 90% in their group. Use the unrelated donor, similar to the matched sibling donor survival. Next, please. The group had a new report in 2019. Totally, about 1,000 thalassemia major were enrolled. The results show transplant considered be early and recommend below 6 years old. So, because this group have the best result, the thalassemia-free survival is the 86%. And the age 7 to 15 years group, the thalassemia-free survival is at the 80%. The two groups, the thalassemia survival rate is acceptable. But when the age above the 16 years old, the thalassemia survival rate is low to the 63%. So this recommend we receive the transplant in thalassemia major below the 6 years or at least below the 50 years old. And another feature show the HLA matched and related donor is a suitable alternative if the HLA matched sequence donor is available. In this future, you can see the matched relative and the matched unrelated donor. The thalassemia-free survival is above the 20%, but mismatched unrelated or mismatched relative is the below 80%. Next, please. So the use of unrelated cord blood for transplant in thalassemia major is hesitated. It has the high incidence of graft failure rate due to the low stem cell dosage. And the overcome strategy is double unit transplant or co-transplant of third-part mesenchymal stem cell. But this transplant suggested in the experienced center only. Next, please. About the haploidentical transplant, due to no available matched sibling donor, low probability of finding a matched and related donor, high risk with cord blood transplant. Haploidentical donor transplant for thalassemia major development in some countries such as Thailand and China, but the transplant has the high risk of graft failure and GVHD, even have the PTCY process prophylaxis. We need new conditional regimen and the GVHD prophylaxis protocol to improve the success rate. Now, the haploidentical transplant for thalassemia major, it is still under investigation. Next, please. Now, I share our experience between March 1984 to the August 2013. 58 patients with thalassemia major received transplant from relative or unrelated matched donor in our hospital. We divide the 58 patients into 3 time periods for comparison. Next, please. Early periods did not have complete risk evaluation, and the condition regimen just only used the busulfan and the endosan. So the NQF rate is not acceptable. After 2000, the condition regimen added the ATG. This result show the NQF increased significant, 100% NQF, and the platelet NQF day is earlier. The platelet NQF decreased to the 28-day recovery. But we can see the venous occlusion disease in thalassemia major is more than other diseases in our experience. Next, please. So in our experience, the early transplantation below the 6 years of age, and the ATG use, better supportive care, can contribute the improvement in thalassemia major transplant. Another is the VOD must be noticed in thalassemia major patient transplant. Next, please. Third, I share our outcome of transplant in the severe combined immunodeficiency. Next, please. We know SCID is the fatal disease. The infant has the SCID, maybe no symptom, and then they suffer from severe infection and the fatal outcome. If the patient did not have the curative transplant, such as the allo transplant, enzyme replacement therapy, or gene therapy, they will fatal in the first year of life in the life. So, SCID is the newborn screening, the favorable and the favorable target, and we can early screen.
What can I say except?
And we can early diagnose the SCID patient in the newborn screening, and we can early treatment the patient before they suffer from the severe infection. So in 2010, the National Taiwan University Hospital newborn screening initiated a parallel newborn screening program for the SCID. We use the method is the T-cell receptor excision circle copy number. And from this report, we can find the incidence of SCID is the 2 cases in the 100,000 live births. This incidence is higher than the previous report in Taiwan. Next, please. We show our result in our hospital. Our hospital starts SCID newborn screening since the 2010. In this cohort, our curator the 6 skin patient from 1999 and to the 2018. We have created 6 skin patients. Before the screening, only one case was diagnosed at about 200 days old. And after the screening, 4 cases was diagnosed about 12 days. So we can see the ski patient is early diagnosis in the screening periods. And the 6 patient total received the 7 transplant. The stem cells 2 is the haploidentical bone marrow, 4 is the unrelated cord blood, and 1 is the matched sibling bone marrow. The condition regimen, 6 received the reduced intensity regimen, and 1 received no condition regimen, but the patient development grade failure. So they received second transplant with reduced intensity condition regimen. Next, please. The engraft rate is the 71%, total 5/6 engraftment in the transplant. The survival rate is the 66%. And in this patient, 1 patient development acute GVHD. And the most common complication after transplant, including the infection, including the bacteremia, PZP pneumonia, non-tuberculosis mycobacteria, CMV disease. And next, this is my presentation, the end. Thanks for your attention.
Thank you, Dr. Lu, for very educative lecture. And we learned in detail on how the selection of donor for various kind of disease, particularly in ALL and also in thalassemia major. Thank you so much. Now we come up to our question and answer session. We would like to invite all the speakers to receive any questions from the participant. And let me see whether there is any questions from the audience. Okay. The first questions is from Dr. Chris Santosa from Surabaya, Indonesia. For Professor Lee Kai-sai, the question is, how many percentage of umbilical cord blood mesenchymal stem cells can homing to the brain via intravenous route?
Okay. Thanks for the question. I have just say that primarily in previous thought, if the stem cell therapy, if the stem cell can have the effect for treatment of ischemic stroke, it may need to homing into the infra region. And in the previous study, there is only about 2 to 4% of transplanted mesenchymal stem cells homing into the infra region. So the homing percentage of or homing efficacy actually is not very high. So in recent years, there are many studies try to enhance the homing capacity of the stem cell by pre-treatment methods. For example, previously we used pre-treating mesenchymal stem cells with valproic acid or lithium, and some study group try to use the deoxygenase mesenchymal stem cell to enhance the homing capacity. However, on the other hand, some study also show that homing of the stem cell into the infra region is not very critical because stem cells still can have some sustaining effect for stroke therapy. So this kind of concept is still under debated. Also, I think that homing is not very critical, but the effect of the optimal treatment for stem cell therapy still should be tested in the future clinical trials.
Okay, so may I say that from your explanation, besides other routes like intra-arterial or directly to the site of infarction, intravenous route is still also be recommended in your.
To me, I think intravenous is the most popular method until now in clinical trial. I think that is really relatively safe. And in our experience in phase 3 clinical trial, even you did not use any immunosuppressant, after intravenous injection of these mesenchymal stem cells did not lead to any allergy response. Also, so it's very special for this kind of cell group. Also, I will recommend use the intravenous therapy for this kind of treatment.
Kai. Yeah, and still from the same doctor, the same, but to Dr. Cheng Hong Sai or Dr. Meng Yo Lu, the question is whether the umbilical cord mesenchymal stem cell can be used for leukemia therapy transplantation in adult and pediatric. Yeah, please. Dr. Sai and Dr. Lu. May I have your comment?
First, and followed by Professor Lu's comment. It's okay?
Yeah, yeah, sure.
I suppose Dr. Chris is asking about the cord blood transplantation, but not mesenchymal.
Yeah, it is.
And for adult patients, as you know, that the one bag of cord blood is not enough for patient more than, for example, 40 kilos or more. So I think the last cord blood transplantation in our institute, adult institute, is more than 10 years ago. So there are still some papers compared haploidentical transplantation and the cord blood transplantation. And as you know, the more and more PDCY introduced in this field. So doctors are more familiar with haploidentical transplantation, not only from patients' father, mother, or of siblings, but also from, for example, aunt or other cousins, or etc. So this PDCY allows us to do transplantations from donors more than 2 degrees. So nowadays, I think cord blood transplantation is not much so popular as 10 years ago. And the second thing I need to mention is that cord blood transplantation will introduce to a delayed the immune recovery compared with haploidentical transplantation. So compared with haploidentical transplantation, the cord blood transplantation will lead to lower engraftment rate, slower engraftment time, slower immune recovery, and lower graft versus leukemia effect. So nowadays we are using haploidentical transplantation much more than cord blood transplantation. How about you, Dr. Lu?
And I agree the comment of the Dr. Chai. And I think the cord blood is the difficult use in the adult because the delay engraftment and the low engraftment rate and the delay the immunity recovery. So here the cord blood transplant is very complicated. But in the children, because the cord blood have some benefit in the timing. So if we arrange a match unrelated donor for the bone marrow stem cell, maybe the time is very delayed, and the donor may reject the donation, but the cord blood is in the bank. So if you match the bag of cord blood, you can use in instant. So we can use the cord blood transplant in 1 month, at least maybe 2 weeks. We can arrange the transplant. So this is it's the benefit. So I think such you can see we do the skin transplant. We use the more cord blood. This because we must we hope we transplant in 3 months or before the 3 months old. So it's a very emergency transplant. So we use much more cord blood. I think the cord blood transplant may be popular in the pediatric transplants only.
Yeah, thank you so much for your explanation, Dr. Lu and Dr. Sai. So there are differences in the choice between umbilical cord blood in adult and in children. Okay, there is another question from Dr. Yasjudan Putra. The question is for Dr. Cheng Hong Sai. The question is, if we plan to initiate a hematopoietic stem cell transplant service, which hematologic malignancy should we start with? And the second one is still for Dr. Sai. Cost remains a significant challenge for hematopoietic stem cell in Indonesia. So what are the main requirements for us to have the opportunity to participate in clinical trials related to hematopoietic stem cell transplant? Please, Dr. Sai.
Okay, very much thanks for Dr. Putra's question. For the first question, I recommend to choose young adult patients with acute myeloid leukemia in their first remission and with matched related donor. So especially for siblings. So there are some key components: young adult, CR1 ML, match related donors, because the complication rate for this kind of patients is much lower. And for CR1 patients, if we dive into more comprehensively, maybe we can choose intermediate risk patient or with RUNX1 mutation patients, because if the patient not respond so well, we can add a little bit, for example, venetoclax to control the relapse rate. But if the patients you choose TP53 is quite high, even after transplantation, the relapse rate is very high. So I think the very first 1 to 2 patients is very critical if we want to establish the transplantation service in a new institute. So it's very critical to pick a very good patient with good donor. Then the successful rate is quite high. So for young staff, for example, the very first year of attending physician and our institute, we will refer such kind of patient for them to practice. This is the answer for the first question. And for the second question, it is not easy because for taking our experience as an example, we established a transplantation, a clinical trial team in hematology division. So there are more than 10 study nurses taking care of clinical trials. So, and I think there are more than 40 clinical trials in our hematology department. So after this kind of service run for more than 5 years, there are some pharmaceutical companies come to our site to try to collaborate with each other. So we need to establish if you want to take part of the new drug trial, we need to establish a trial team first, because in Taiwan, taking other hospitals example, I think the trial starts only in, I think maybe 4 to 5 transplantation centers even though there are 23 transplantation centers in Taiwan, but all these trials also happens within 5 hospitals or 3 hospitals. So the common features of these hospitals are they have a strong clinical trial team, a big trial team covering acute myeloid leukemia, acute lymphoblastic leukemia, and non-Hodgkin lymphoma. So these are key features for pharmaceuticals to choose our institute to take part in clinical trial. But if you are concerned about the cost, I need to mention that the cost only, for example, for Velati, the pharmaceutical company only pay for venetoclax and azacitidine after transplantation. But all the transplantation cost is paid by the national health insurance and the patient themselves. So only cover the drugs only, but not the transplantation process. So it takes, I think, more than, for new Taiwan dollars, I think it takes around 3 million to 5 million per patient in the total process. But if you are asking about after transplantation to their first discharge, it takes about $1 million.
Okay, thank you, Doctor, for your answer. And still connected with Dr. Putra's question, I learned from your presentation that in Taiwan, the use of PBSCT is more frequent than bone marrow source, and we understood that it has many advantage over bone marrow source. However, when seeing the GVHD risk, particularly in the chronic setting, then it becomes a continuous treatment for the patient, and of course it will cost a lot in terms of logistics. Yeah, and do you have any suggestion for us in Indonesia for which methods to choose regarding or considering this logistic issue, whether the bone marrow source or peripheral blood stem cell, which is more practical, but of course the trade-off is also very expensive. Yeah, any
Yes.
comments, Dr. Lu?
I would suggest to use peripheral blood because the immune recovery phase is very quick and robust. And as you said, that the GVH rate is a major concern. I totally agree that even for matched sleeping donors, if we are not giving ATG, a lot of patients will have chronic, especially chronic GVH after 1 year. It is a very devastating complication. So in current status, we are using a little bit ATG in even matched related donors. For example, 2.5 milligram per kilo for thymoglobulin. You can see a lot of different regimens using horse ATG, ATG Fresenius, or thymoglobulin. And in our country, in Taiwan, we only have thymoglobulin, so we're using 2.5 milligram per kilo per day for 1 day. For some physicians at our hospital, we're using 2.5. I think maybe a little bit, maybe a few colleagues at our institute using 4.0, but I think it is quite more, and patients might expose a higher risk of viral or fungal infection afterwards. So I would recommend 2.5 ATG and plus peripheral blood stem cell transplantation. It's quite good. And as you just like you mentioned, I think bone marrow transplantation, especially bone marrow, costs a lot of resources. We need a lot of physicians. We need at least 4 physicians to enter the operation room to get the stem cell, and only, for example, CD34 around 2 million or 3 million. But for peripheral blood, it's quite easy to get more than 5 million. So very easy to get the stem cell, easy for donors to complete the process, and a faster immune recovery phase. So I would recommend peripheral blood as a source.
Okay, and the management of GVHD is a fair trade-off for using PBSCT. Yeah.
Yeah.
Okay, Dr. Sai, thank you so much for your answer. Maybe another 2 questions. First is for Prof. Lee Kai Lee Kai-sai, we have learned a very promising use of stem cell with or without a combination with other substance with neurogenesis potentials from your lecture. And do you have any recommendation or suggestions for its use, whether stem cells only or stem cells plus those substance, particularly in daily practice in terms of patient selection, Prof. Lee Kai-tai?
Okay. First of all, I would like to mention again that the stem cell therapy in the stroke field is still immature in clinical practice. And although there is many positive response in the preclinical study, but there is still no phase 3 clinical trial proof that the stem cell therapy is effective in stroke patients. So, but I think that it's encouraged to start the stem cell therapy research in stroke field. So, if it's possible to perform any stem cell therapy in patients, it should be very careful to manage the patients with very detailed record and compare the result to increase our understanding of stem cell therapy. And to collect the patients, I think that for stem cell therapy, it can first try to do the acute treatment. That means that collect the patient with acute ischemic stroke. Because current evidence have shown that the stem cell therapy, the mechanism of stem cell therapy is primarily not related to cell replacement. So if we want to rescue this neuron or other CNS cells away from damage facing in stroke, we should treat that as soon as possible. For example, 1 to 2 days after stroke. So collect a patient with acute stage will be my suggestion. And of course, I just say that maybe we can combine the stem cells and the growth factor or some small molecule. But because the treatment is not immature enough to say any conclusion, I would suggest to do one thing at one moment. First, to try to confirm that stem cell is effective, or a certain molecule or certain growth factor is effective in stroke patients. And in the future, maybe possible try to combine certain therapies in the future. Thank you.
Yeah, thank you so much, Prof. Lee Kai-sai, for your very considerative and encouraging recommendation to continue the clinical trial on this very specific treatment of stem cell use in stroke. Thank you again. And maybe the last two questions for Dr. Lu. The first one is, in cases of benign hematologic disorders such as thalassemia, what is the significance of hematopoietic stem cell transplant when comparing its benefit and risk? Of course, compared with without transplant.
I think the thalassemia major patient, I introduce the thalassemia major treatment. You can select the conventional supportive care, but they just use the regular transfusion and the iron chelation therapy. But the patient quality is worse. They may need to go to the hospital every 2 to 4 weeks, and they need to regular take the iron chelation. So, and the economic effect is the lifelong. But the thalassemia major receive the transplant, they only receive the one one risk for the transplant. You can receive the conditional chemotherapy, and maybe they have some GVHD the risk. So you must balance this the risk and the benefit. In Taiwan, our patient we have the thalassemia major screening. So now our all patients, nearly all patients above the 30 years old. So if they receive the chemotherapy, receive the transplant, it is the more risk. So you can see our report after the 21 and 2010 years, we did not do any thalassemia major patient transplant because we have no suitable patient to do. But so our all patient only receive the regular transfusion and the antigen therapy only. So to this patient, their benefit is the continuous supportive care. But if we have one children just birth, like below the 6 years old, we have the to search the suitable donor. And if the suitable donor, like the match-related donor or match-unrelated donor, we also recommend they to receive the stem cell transplant. And in some patients, we have because the thalassemia major patient can survive long term. So maybe we have the suggestion the parents maybe carry a new baby, maybe the match the relative donor, they can lower the transplant risk. So, but in our medical economical the analysis, the patient receive the transplant, the whole life expected for the economical support is lower than the supportive care. So I know in the Thailand, in the Malaysia, or maybe in the China, they recommend the patient receive the transplant.
Okay, yeah. Thank you, Dr. Lu, for your answer. And maybe the last question for you. You mentioned that allo stem cell transplant is reserved for children in the CR2 period. And how is it in the young adult ALL? Because it's like the transitional between children and adult. And usually we have ALL in not older, yeah. Is there any special comment about this? Whether to wait until relapse and then give it back to the CR2 or directly on the CR1? Maybe Dr. Lu or Dr. Sai can answer this.
I first comment answer because in Taiwan we have the Taiwan Pediatric Oncology Group, and we have designed the TPOG acute lymphoblastic leukemia treatment protocol. And the survival rate in the protocol is over 85%, and in the standard risk maybe more than 90%. So the patient receive the ALL, the patient receive the chemotherapy, the survival rate is very high. So only the 10% patient relapse. So in the pediatric ALL, we did not receive the transplant in the first remission status. Maybe the patient relapse, we try the chemotherapy or the new immunotherapy, then the patient achieve the second remission. Then we do the transplant. And now in Taiwan, we have the CAR-T, maybe we do the CAR-T, let the patient have the long-term survival. But I think in adult, in the adult ALL is another condition.
Okay, maybe Dr. Lu can, Dr. Sai can add some comments on this.
Okay. For example, acute lymphoblastic leukemia adult patients, if we divide patients into Philadelphia chromosome positive or Philadelphia chromosome negative, and for every patient with Philadelphia chromosome, everyone goes to transplantation treatment, because as you know, that there are more and more literature discussion about using, for example, ponatinib plus blinatumomab, then patients might be free from transplantation, or from the GRAIL group that using the ABBA trial, that using dasatinib and blinatumomab, then around 50% of patients can free from transplantation. But for us, blinatumomab for 2 to 4 cycles is quite expensive, especially not reimbursed by the government. So most of the patients with Philadelphia chromosome, we use TKI, tyrosine kinase inhibitor, with chemotherapy, either with DVD, is a low intensity regimen, or standard GRAIL regimen, then followed by allotransplantation, and the end followed by TKI maintenance for around 2 to 5 years based on the MD Anderson data. And for Philadelphia chromosome negative patients, it's quite diverse, because in the old times, we used to transplant every patient. But for now, I think for the past 7 to 8 years, the practice are changing, because there's a EBMT consensus, I think in 2018 or 2019. They say that if the patients got complete remission without measurable residual disease after induction, and the patient received pediatric inspired regimen, then the patients can free from transplantation. So currently we're using GRAIL induction, which is a pediatric inspired regimen. Then, so if the patient got MRD negativity after induction part 2, then we don't refer the patient to receive transplantation, except those with, for example, ECARS-1 or other high-risk features. Then we still refer the patients to receive transplantation. But I need to mention, refer such kind of patients is not fully compatible with the EBMT guideline, but because there are very little data describing such kind of patients with high-risk genomic features. So for complex chromosome or for hyperleukocytosis patients, if got complete remission, I will try not to go to transplantation, but I think the practice are quite diverse, especially in our hospital.
Okay, Dr. Sai, thank you so much for your answer. There is another, maybe this is the one last questions before we close, and before we close the session. It may go to Dr. Sai again. Has secretome infusion been done in NTUH? And if the patient has financial issues, can hematopoietic stem cell transplant be replaced with secretome infusion? Thank you.
So familiar with secretome.
Yeah,
I think we don't
nowadays
have
it's getting, nowadays in Indonesia it's getting more popular, the secretome. Maybe Professor Kai can give some comments on that. It's like kind of exosomes produced by certain kind of cells in the body, and it can be used for many kind of adjuvant treatment for many kind of disease. So probably this question arises from that idea.
Okay. Maybe I can share some thoughts first, and followed by Professor Chai or Dr. Lu. And I think the exosome is quite is becoming more and more popular in Taiwan in recent years, but under current regulation, it is not allowed we doctors to give exosome unless we are permitted. We give some application and permitted by the government. And as I know, for now, for the health organization of our government, there's no approval regulation for patients with hematologic malignancies to receive either secretome or exosome as a replacement for hematopoietic stem cell transplantation because of regulation issue. So we are not so familiar with its practical implication.
So still a hematopoietic stem cell transplant is irreplaceable, yeah, at the moment. It's still the main treatment, okay. Any comments from other doctors?
No.
Okay. Okay, then thank you so much for all three wonderful speakers. Professor Lee Kai Sai, Dr. Cheng Hong Sai, and Dr. Meng Yo Lu for your very wonderful lecture and inspiring comprehensive talks. And now we are going to close this session, and we are asking all the participants to open up the camera and open up the masker so that we can have our picture taken together. Yeah. Bisa dibantu. Okay. 1, 2, 3. Smile. We'd like to have berapa kali, Mas? Satu aja cukup. Okay, then thank you so much again for three wonderful speakers and all participants who have been actively listening and participating in this session. I, as the moderator for this session, again say thank you and have a wonderful day. Yeah, have a good day. Thank you.
Thank you. Bye-bye.
Bye. Udah ada emailnya. Ya, oke.
Okay, thank you, Dr. Martia, for the exciting discussion and also skillfully leading our discussion too. Okay, I think this is the end of our webinar. Johanna will bring this webinar to a close. Thank you so much to all the participants who stay with us until now, and see you in our next event. Terima kasih dan selamat siang.
Siang.